Hello, I'm Courtney Bitz, and I am really pleased to be here with you today. I really appreciate the invitation, and I'm excited to share with you a little bit of the work that we've been doing at City of Hope. I am a clinical social worker by training, and currently the director of clinical social work at City of Hope. I've worked in the field of psycho-oncology for just over 19 years. And I've specialized and have a unique passion for working with couples who are coping with a cancer diagnosis. I wanted to talk with you a little bit about City of Hope and the department to give you some context of the environment that I work in. So City of Hope is one of 45 national comprehensive cancer centers in the United States and is located in the state of California, just outside the city of Los Angeles. Los Angeles is a large, diverse community. And I think one of the things that makes City of Hope unique is the focus on caring for the whole person and not just the disease. The image that you see on the left side of your screen is our Golter Gate on our campus. And Samuel Golter was one of the founding members of City of Hope. And he famously said that there is no profit in curing the body if in the process we destroy the soul. And that ethic and value is what makes City of Hope special today. So the Department of Supportive Care Medicine is the large group of people that you see on the screen, and they really bring this value to reality at City of Hope. We are 146 strong, and we are truly a national model for this innovative, integrative way of providing patient supportive care services. We have a team of experts that include pain and palliative care physicians, nurses, psychologists, psychiatrists, social workers, spiritual care chaplains, and more. I know that, when we talk about that, I know that we're very unique in a sense that we have resources that not a lot of cancer centers, even the United States or across the world, have. And so with that, we think about our privilege in that, and also making sure we're bringing back to the community and sharing what we've learned and sharing what we have developed with others so that it can be multiplied and benefit individuals with cancer all over the world. And that's what I'm hoping to share with you today. So before I go into the summary of what I wanted to share with you, I really do want to acknowledge that, I'm going to be introducing concepts that worked maybe for our community or the Los Angeles area, but it's not necessarily going to be exactly replicated for a different culture, a different community, a different practice setting. And so I'm hoping that just the concepts I bring, you might be able to think about how you can tailor and apply these to your own unique setting. And we can hopefully, talk a little bit more about that throughout the presentation. So today I wanted to share with you 6 core concepts that I thought about when thinking about supporting families and couples during cancer. One, we know that cancer patients and their families are experiencing significant distress. And that it's important for medical teams to be able to ask our patients and ask their partner and caregiver about that distress. We also know from research that supportive relationships have protective factors and in cancer care and in medical outcomes. And that medical teams can really help patients by normalizing and destigmatizing distress and differences in coping with that distress. And then I hope to share with you some really practical behaviors and skills that we have shared with couples that helps them emotionally support and solve problems together, even despite the challenges of cancer. And then lastly, I would like to kind of describe how integrating psychosocial interventions or into medical care can actually positively impact not only patients and families, but providers as well. So evidence is really clear that cancer patients and their families experience significant distress. In fact, 1/3 of all cancer patients experience high levels of distress. And that distress really does impact the medical outcomes. We see with high distress a decrease in the patient's ability to adhere to the treatment recommendations, increased relapse and decreased survival rates, and also a higher medical cost and really a greater burden on the medical system in general. And we often talk about distress as an emotional symptom, but I'm going to introduce it in terms of a different concept on the next slide. That distress is really biopsychosocial distress and not just emotional symptom. So first, let's talk about biopsychosocial screening. This really is a brief method of prospectively identifying and triaging cancer patients at risk for illness-related biopsychosocial complications that will possibly undermine their ability to fully benefit from medical care, the efficiency of that clinical encounter, satisfaction, and safety. But I want to talk a little bit about the components of biopsychosocial distress. So our patients will often, and families often, experience physical, psychological, emotional, social, spiritual, and practical components. Let me give you a couple examples, and then I'm going to ask you to think a little bit about how you might think about your patient population in terms of these components. So physical is often what patients reporting difficulty managing side effects from treatment, pain, lack of sleep, fatigue. Psychological can include feelings and symptoms of depression, anxiety. Emotional is often about, a worry about the future, or how do I manage these emotions that I'm feeling throughout my cancer diagnosis and treatment. Social, we often see patients really experiencing distress related to the impact on their family, their children, their job, and even, simple things like their roles and responsibilities in the family. Spiritual distress, we often hear from patients that either they start questioning some of their spiritual beliefs in the light of the diagnosis, or they're struggling with integrating their diagnosis into their spiritual beliefs. And then lastly is practical components. We know cancer care and cancer treatment can be incredibly expensive. And at the same time, patients and families might be not able to work as much as they used to. They have increased medical costs, a lack of a job, and how are they even going to get to their treatment? These are all a reality, I know, for our patients here in Los Angeles, but I imagine in your setting as well. So just take a moment and think about your patients and the patients you've encountered in your community and practice, and how might you be able to ask some of these questions or inquire about some of these areas of distress that are most impacting your patients and their ability to really engage with you in their medical care. So I wanted to put this concept of distress in kind of give you an example. And this is a data set from our Couples Coping with Cancer Together program at City of Hope. And we've screened 853 women with breast cancer and 755 of their male partners. And this is the data of the highest areas of distress they reported. And it's only reported from moderate to very severe. So think 3, 4, 5 on a 5-point Likert scale. And you'll notice that in this mix is just the concepts that I just spoke about: psychological distress, emotional, financial, worry about my family, understanding my medical care. But what I really want to highlight here is the two red boxes. And I think it really was evident when we started looking at this data about this shared experience of anxiety and worry that our patients and their partners are experiencing at the same time. And when you think about it, we ask partners to really sometimes change their, be part of the medical team, change their roles, take on new roles within the family, support patients in a different way than they've ever had to. And at the same time, they're experiencing significant distress themselves. And oftentimes as a medical institutions, we're not really asking caregivers or patient partners about their distress or even providing an intervention. And so I think this really does show that, our patients and our partners really need as a medical team to be really asking and looking for some of this distress. Okay. So you might ask yourself, why are we even talking about couples and relationships and partners at a medical conference? And I want to say that it's because there's an enormous amount of research out there, and from these several meta-analysis studies, that individuals who are in healthy, supportive relationships live longer and better. And we also know that supportive relationships can have protective factors in cancer care. So there's a lot of research out there that shows not only does a healthy, supportive relationship help with emotional and psychological coping and adjustment, but also impacts cancer detection rates, treatment adherence, and again, survival rates. And so partners are really an important part of that support. Obviously, we have families and friends, but what we've also found in the research is that there's a specific concept about partners and their support that really matter and can't be replaced. So for example, women with breast cancer whose male partner provides emotional support, and that's defined as high empathy and low withdrawal, really play a pivotal role in adaptation and psychological adjustment, but also we've seen in surgery recovery and decreased pain after surgery. We also know that there can be an unsupportive partner cannot be replaced by multiple supportive friends. And so we really want to target on how we can enhance that unsupportive behavior to help support this patient and this partner through their cancer treatment. And interesting enough, we find that men who have cancer, they often only rely on their spouse, not only for practical caregiving, but also they don't discuss what they're going through with anyone else besides their spouse. So this relationship, this context is a real resource for us as medical teams. So I'm going to move into the concept of how medical teams can really destigmatize and normalize distress during cancer treatment and differences in coping. And I want to start with some concepts about stress inclinations and what we do, our natural inclinations during times of stress. So population-based literature really supports that gender matters when coping with stress, and that men and women tend to respond differently. I want to stress here that, sex and gender are not determinations, but they're inclinations, and not everybody fits into one box or the other, that there's often a continuum. And what matters most is that we know this about ourselves and we know this about our partner. So the fight and flight response is really, the put up your dukes and fight, or hightail out of a situation as quick as possible. When men are diagnosed with cancer, they're not literally putting on their boxing gloves or fleeing the situation. But what we do find is that you might see some of this fight behavior in terms of their ability to advocate for themselves or their partner if their needs aren't getting met with their medical team. And then the flight is, we often see men might go for internal resources when they're trying to cope or problem solve during times of stress. The stress response most associated with women are the tend and befriend. And I think we hear less about this, but the tend response really is referring to how women will engage in nurturing activities to make sure that they're protecting themselves, their offspring, and to promote safety. Befriend really means that they're creating a system and a social network and reaching out for help from others to get support and information in times of stress. And I want to say before I move on, there's no right or wrong stress response. Any one of these behaviors that we naturally have can be a strength or not, or a challenge depending on the context, right? We can think of ways where it really is important that we flee a situation for our safety. Whereas other situations, having the ability to reach out and socially connect and get information might be the more adaptive stress response. So in our at City of Hope, we have a psychoeducational session that we have with patients and their partners right before the medical consultation. It's 30 minutes. And what we try to do is we open up this session is really start normalizing, destigmatizing, and giving these couples hope. And so I just want to read, these are actual quotes from our scripting. I just want to read these for you. And I thought it might help to give some terminology that you might be able to adapt in your own context. So we start with saying, I'm going to share wisdom from past patients and partners, research, and our own clinical experience about what's been helpful for other couples navigating this journey. That cancer affects the whole family and impacts many areas of one's life. And you are both essential members of our team. For most people, when they hear the word cancer, it's a common reaction to have fears and concerns about what does this mean for me? What does this mean for my family? And even have thoughts about death. Whether these fears are rational or irrational makes no difference. And despite these stressors, many couples and families tell us they grow closer together. And this is an opportunity for you to both role model for your family. How do we as a family want to manage difficult times? And then lastly, from this moment forward, you can live the relationship that you want and make decisions and be the partner that you would be proud of looking back. So I'm going to move into the part of the talk about there are practical things and skills and things that men and women can do to really best support each other during times of stress. And I believe, this document that's on the slide you'll be able to download that and get that and keep that so you can actually read it. But I'm going to go over a few things that we share with couples in that session. So how do we get all of this wisdom? Well, our team have over the last 15 years have really went around the world and asked men and women, what's helpful, what's not helpful, what do you wish you would have known, done, not done when you were going through a cancer diagnosis or someone you love was going through. And we've really gathered this wisdom and data and then looked at it in terms of the research and shared this with couples. And so this is an example of how we use gender to help men understand how they might be able to best support a woman they love. And I think I want to target this in this concept of really being able to encourage their partners to talk openly and honestly about their fears, irrational fears, rational fears. And this is where we really ask men to be courageous enough to listen to the woman they love, to talk about her concerns and not try to fix them or minimize them by reassuring her or giving her advice in that moment. Women tell us just having a partner that would just openly and actively listen during this is probably one of the most helpful things that they can do. And that's hard. That can be hard for partners because they love their partner so much. It's hard to hear your partner be under distress and not be able to feel like you can do something to fix it. But what we do know is there are things that partners can say that are based in reality, right? So things like, no matter what, you can count on me. And that's the type of reassurances women really respond to. I'm going to move on next to what we share when there is a male patient and a female partner or caregiver. And here we highlight that differences in coping is not necessarily right or wrong. And I often hear a lot of caregivers who are women wanting me to help encourage their husband to talk more about their emotions and their feelings. And I often have to talk with them that, women often do benefit from talking openly and honestly and sharing their feelings, even if the outcome at the end of that doesn't change. But most men, I'm not saying all men, they tell us they typically don't always receive that same benefit in coping, that they often need time to internally kind of think about a subject sort out their thoughts and feelings and what they might need before they share. So I really often ask women to respect that difference from their partner and know that their partner is kind of using their own individual coping mechanisms that will help them through the process. And then lastly, we talk about this with all couples, and we hear this a lot in our group, our couples group, that couples really feel that trying to find some sort of way to connect and create joy in their relationship and in their family and their lives as they're navigating cancer is extremely important in the long run. Cancer can become a full-time job, totally overwhelming all type of interactions or communications. And just to think about the little things that a couple can do or a family can do that bring some joy back into that process is really important. So I wanted to give a kind of a scenario of a couple that we worked with here at City of Hope to kind of highlight some of these topics. So Sarah is 33 and she's married to David for 6 years. And Sarah just completed a year-long treatment plan for breast cancer. She's attempting to return to work and resume her responsibilities at home and with their 4-year-old son. But Sarah's having increased anxiety. She's having difficulty with concentration at work. And she even experienced a panic attack episode when she was out with her family. Sarah doesn't feel that David is supportive of her and kind of expects her to do all of the things that she used to do and be who she was then. And they've been arguing more than ever about this concept. So I want to conceptualize kind of how we use gender strengths and this concept of natural inclinations in working with couples. I think the first thing that we had to really do with Sarah and David is really to talk about this, again, this natural inclinations during times of stress. So David, he was very protective of Sarah. He just wanted her to be okay again. And when she was talking about challenge, he just wanted to fix them. For example, she was talking about how much trouble she had at work and he says, just quit your job, we'll figure it out. And that was his way of thinking he was supporting Sarah. But Sarah wanted to feel heard and validated and understood and was questioning, is this me, a problem with me, or is this normal to be feeling it this way? So then when we kind of talked a little bit about their natural inclinations and what they needed from each other, I think it's really important to talk with couples about what's underneath that motivation that's underneath the behavior. Oftentimes, if we just go with the behavior, we make assumptions about our partner's intentions that are not true. So we really started talking about why was David so focused on just moving forward. And we started an open and honest communication about their fears and concerns. David was incredibly relieved that Sarah was safe and alive. And that year that she underwent through treatment was torture for him. He was really scared. And Sarah was scared that if she was never able to kind of resume back to who she was before she was cancered, questioning, would David leave me? And when they heard that and were able to think about what each other were thinking and experiencing, it really connected them in a different way. And then we really focused on using both of their strengths to solve problems and cope with the challenges. So David's strength was that he was present and future focused, that he could think about the future with his family and not getting stuck in the past. But he was also able to problem solve financial and practical concerns. And he had a strong desire to really create some joy in their relationship and their family. So Sarah's strengths were she's able to be reflective and insightful about the past. And she really helped lead their family to redefining what their priorities were, what their values were, and what made life meaningful. And that was different than what previous to the cancer diagnosis. She also had an incredible amount of social connections, resources from friends, from school and church that really was able to surround this family and help them solve some of the problems they were experiencing. So now I want to end with the last bullet point, and that was that integrating some of these concepts into medical care can really not only help support patients and families, but also providers. So we collected some program evaluation data for 430, again, breast cancer patients and 385 of their partners. And what was interesting that we found out is that all along the way, partners were rating the program and the interventions even higher than patients themselves. And remember, these are male partners. And I'm not sure about your experience, but I know in the United States, at City of Hope in our community, it is really challenging to engage men in psychosocial interventions. And I think this is really a testament to when you really think about and integrate gender and strengths in your language, in your interventions and program, it can really engage the diversity that is in within our patients and their partners. Interesting enough, soon after we started working with this program, we started hearing and a lot from medical providers about the benefits they were experiencing. Many of you know that initial consultations or consultations with patients who are experiencing a cancer diagnosis that are scared, they can be really emotionally charged consults, and many difficult types of topics can come up. But what we found is when we were able to meet with the couple before the initial consultation, we were able to kind of relieve some of that distress and give them some appropriate counseling and communication training. So then when they went in with their physician, they were less distressed, calmer, more focused. And the doctors told us they were really able to focus more on medical care and their consultations were more efficient. So we actually did some evaluations with our physicians who participated. And this is just a few of the concepts. But what we found from our providers that they really strongly agreed that having their patients and partners engaged in the medical care and treatment decision making really mattered. That they felt it was incredibly important that their patients and families' distress was being addressed early and by the team, and that it was really important that their patients and partners were communicating effectively, not only with each other, but with the medical team. And so I really hope that maybe thinking through a little bit about how, as a multidisciplinary team, we can support our patients and families and our providers, allowing them to do what they do best. And that's provide medical recommendations and treatment. So that's what I have to share with you today. I'm really hoping that just one or two of these concepts may help you think about what you can apply in your own setting, in your own population. Obviously, like I said, I'm wanted to share my contact information, my email, because I really truly believe that we're a team and that the more patients and partners that we can support, the better our world will be. So thank you so much for your time.
Hi, Courtney. It's Ken Miller, and I want to say hi to our participants and our the large group of people who are watching it. See, thank you so much. I'm very admiring of the work that you do, and also the support of the City of Hope, which is unusual. Really a role model. So I did get a couple of questions emailed into me during your talk, and let me pose them to you. I wish we could do it live, but we're not quite there technologically. I wanted to use this is a colleague from Ghana who's writing, and the topic they bring up is truth telling, and essentially what it's a long, essentially. When someone has cancer, let's say advanced cancer, and is likely going to die of that disease, what are some tips that you would give? What's your insight and any anecdote too about how couples in that situation can communicate who perhaps not communicated deeply before?
Right. This is a great question, because we find this, and I think we find this a lot because, sometimes because patients and partners or couples or even families love each other so much, they often want to protect each other during times, right? That the patient doesn't want to burden their family with what they're thinking or feeling, and the partners don't want to add distress. And so often what we find is this protective behavior really makes them feel disconnected versus connected when it matters the most. We talk a lot, even with, couples, about talking with their children and their families. That open and honest communication really allows these two people, these that love each other, to really support one another and not feel so alone in probably what they're having similar thoughts and feelings about. It's almost a relief that they can hear and talk and openly about what they've probably been dealing with individually themselves. So we really encourage, this concept, and even to be honest, with medical providers, right? Sometimes it's hard to even tell our patients, our families, that unfortunately, the cancer treatment or the cancer is not what we had hoped for. But by communicating and role modeling that we can talk about anything and everything, and we're going to be there together to support them as a team, really goes a long way as well. I hope that answered your question, or if there's anything I can add,
Yeah.
please let me know.
We had another question from a colleague in Zambia, and it's talking about again, a long paragraph. I'm going to paraphrase it. How can a partner share their own stress, which can be overwhelming when the person you love is sick? You share that when their partner is so sick. There's a feeling of how can you add more demands to someone who's already struggling?
That's a great question. And again, they're hitting on a lot of the topics that we hear about in our clinic. And this happens a lot because caregivers also often carry such a large burden. Interestingly enough, in our research and our experience, when we're talking with women especially, they tell us that one of the ways their partner can actually help support them is talking to them about how the illness is impacting them. And I'll tell you the reason why. Oftentimes, women will be there wondering, am I the only one who's worried about this? And maybe they don't even care that I have cancer because they're acting normal and like everything's okay. And it can actually increase their anxiety. But that when they hear from their partner how it's impacting them, it actually makes them feel more reassured and less worried about what their partner may actually be thinking or feeling. Because a lot of stories can come up in one's mind, especially if you're feeling vulnerable, about the whys behind a behavior. And that's why I talk a lot in that case scenario about really asking about the intentions. Oftentimes people don't want to talk about things because they're scared or they don't want to burden others.
Yeah, so it's actually paradoxical that
Mhm.
sharing those concerns is helpful.
Yeah, it is. Right. And I see so many when I have a couples in front of me, or we're talking about this in our groups with couples, see so many shaking heads from women who really do want to hear. And I think also, and I don't want to just say women, but they want to hear from their family because it's isolating to feel like you're alone. And then to think about, then we can put our efforts on supporting each other through this process.
We have a question from Paula, and it's related to sex during cancer.
Yeah.
Sexuality and intimacy is something that brings a couple together.
You're right.
And both partners may actually want to have that closeness, and yet sometimes it feels like it's the worst time. It's asking or wanting something that is not appropriate. Well, what are your thoughts on that? And what have you heard from agents and partners?
Yeah, and I'm glad, honestly, Dr. Mel, I'm really glad you brought that up because we don't talk about that enough with I think as medical providers with our patients and partners. And so, I think some of the same concepts that we talk about when we're talking about open and honest communication apply here as well. I have often heard that from couples, for example, like if after surgery or after specific changes to one's body, that they're either not wanting to show the changes, and the partner is also not wanting to offend or to, cause distress to the physical changes. So we really encourage couples, especially when we're working in our surgery clinics, to have immediately after surgery, after surgery, soon after, to really show and talk about the changes to the body as a couple, so that it doesn't turn into something that is almost like an elephant in the room, right? A secret. And that way the partner can also be there to help care and nurture. And when we encourage couples to do that, we really do hear a lot of positive feedback, that it's early and it's not building up into something. In terms of navigating like the changes to a sexual relationship or body, I think we talk about with couples of like lowering their expectations. Usually it's self-imposed expectations about what their sexual relationship is going to feel like and experience, and just to start being curious with one another and start navigating this kind of new way of being, but doing that together, and doing that with open and honest communication and curiosity. It's not easy, but I think couples that do talk about it and share their emotions and their feelings really are able to navigate into this new way of being that makes them feel intimate and emotionally connected at the same time.
Yeah, thank you. Thank you. I wanted to bring up sort of, let me ask a question for myself now too. I did a survey with a couple of medical residents on use of the word death in cancer care.
Yeah.
It's not used very much. Again, this was a survey here in the US of, it was 130 oncologists. And I don't know exactly what things are like in Africa.
Right.
It's not a word we use a lot. What have, again, couples said to you about use of the word death? If, and maybe the fear of death, or maybe the death is soon or coming. What are your thoughts on that?
Yeah. Well, you'll notice in the slide, in the script, within the first 10 seconds, strategically, we did this. In the first 10 minutes that we're in a room with a couple for the very first time, we say the word death. We say it's normal, it's a normal reaction, it's rational, irrational, doesn't matter. And that way we're role modeling for them. We can talk about difficult things. We're not shying away from it. You two, we're here to support you. And you will be, it's really incredible to see these couples kind of just like loosen their body language. Often, sometimes there's tears that come because they've been thinking that, but they've been, not knowing how to express it. So I think it is something that is in our, like I said, at City of Hope, in our research, is that when we say that as a medical team and we're honest, we're really being role models. Because again, if we're not able to talk about our fears, rational, irrational, we're going to be isolated and alone during a time that we really need this couple to be supporting and solving problems and having these kinds of conversations. So we have, in all of, we've been doing this for 7 or 8 years here. I have never had a couple tell me, why did you say that? Even when, this diagnosis was very curable, because it's just our human nature to hear that word cancer and think about death. And so how can we open up that conversation for the people that we're working with in a medical setting?
And a last question,
Sure.
at least from me, that we may get another email, but talk about it a little bit, or ask about a little bit about from the provider's point of view. It is typically office hours, clinic hours are very busy. We're seeing a lot of patients, and there's a lot of very sick patients. And there's sometimes the worry. I'll speak in the first person. I may worry.
Yeah.
Geez, I'm a little bit worried about bringing up something that I don't know what to do about. If I say, geez, how are things with sexuality and intimacy? If someone brings up, geez, we have a big problem, what will I say? Or if I talk about death, or bring that up. Am I equipped to deal with it? So I wanted to ask you, looking at City of Hope, looking at other models you've seen, how can tell us about the team? Who is a multidisciplinary team, and what are some of the strengths of that?
Right. I think so. In the Department of Supportive Care Medicine, I think we often think of our audience or our customers or patients and families, but we really put on top of our list providers, medical providers, because we really see ourselves as helping the providers be able to do what they do best, right? And that they can focus on what they can do best. Not one person is trained, in all these different kinds of expertise that really enhance patient care. So I know for like the couples program, when we were building and developing it, we really had providers on our top target of how are we going to support these providers, because they have double booked patients and clinics that are running. And so what we thought we could do, and I remember one oncologist telling me this, I just want to know that you know about the problems, Courtney, and you're going to do something about it, right? And not because she didn't care, but that was what was helpful for her. So I think if there could be, a team approach, and I understand, we are very fortunate at City of Hope. Our team consists of a lot of different experts. But I think if you think about our basic model, our basic model is screening. So asking some specific questions that maybe that you can do something about, or you have somebody that can help you. And two, having an alternate team of, a social worker, a chaplain, a pain and palliative care physician. I mean, that's the multidisciplinary team. But even if you don't have that, how can we work with, I don't know, nursing has such a level of expertise as well. So trying to find a way to expand maybe a little bit of the team to add different expertise in some way that they can help support the physician, so that they can see all, the clinic patients that are standing there waiting for their expertise. I hope that summarized that. Okay.
Very much so. Very much so. Thank you.
Yeah.
Thank you.
Yeah.
Well, let me ask you as we sort of wrap up, but any closing thoughts that you want to share with our group?
Thinking about this talk and this presentation has been very humbling. To be honest with you, I wish I was in the room with everybody and interacting so I could learn just as much as I hope I shared today from all of you. But I think, if I were to kind of end with something, I would end with, when you look at this presentation or you think about these concepts, start small. Don't, just even if you ask one question, one area that maybe your patients are experiencing the most, that's something. And I think when we try to do too much, too big, it can almost feel immobilizing. And that's kind of our concept at City of Hope. Matt and I started maybe 7 or 8 years ago with one doctor in one evening clinic seeing, 2 to 3 couples a week. And if we had tried to do it, make it as big as it is, now, we would have never succeeded. Because so one thing, that one impact, or, one doctor, one, group of patients, that's what I would recommend, because it can easily become overwhelming and then and no progress can be made. So start small, go slow. That would probably be my biggest thoughts.
Always good advice. So thank you.
Yeah.
Anyways, on behalf of the organizers, and Courtney, I want to thank you so much, Courtney Bitz from City of Hope.
Thank you so much. It's such a pleasure.